Hi, I'm Tony DeMaria from UC San Diego. I'm here in San Francisco at the TCT meeting, again to bring you some highlights of the late-breaking clinical trials. And to do this, we have two super experts, Deepak Bhatt to my left from Harvard, and the editor of JACC Interventional Cardiology, Dr. Spencer King. So I guess, Deepak, the most interesting trial in the last session was CHILL-MI.
Yes, this was a very interesting study examining hypothermia in myocardial infarction patients. Of course, hypothermia has become very popular in cardiac arrest, both in terms of trying to prevent heart muscle damage and brain damage. But this study was looking at patients just coming in with an MI, not necessarily those in extremis, and the primary endpoint was infarct size, to see if hypothermia would reduce the size of infarcts.
And they did hypothermia by an endovascular procedure, the primary endpoint being infarct size. What did I find? Let's get right down to the bottom line.
Sure, so a little bit disappointing for the primary endpoint, no significant difference in infarct size. It was 13% lower in the hypothermia group, but that wasn't statistically significant in the overall trial, so strictly speaking negative. But in the subgroup of patients with anterior MIs treated within 4 hours, so big MIs, getting to them soon enough, there was a significant reduction in that subgroup, albeit not in the overall trial.
Yeah, it's kind of difficult often logistically, isn't it, Spencer, to get to these patients with acute MI when everything else is going on, PCI and whatnot, and to do the endovascular cooling.
Yeah, I mean, the people who are getting cooled are the people who are out cold, so to speak. That is, the people who are unconscious, who've had, who've had arrest or something. We're not doing cooling, right now. So it's an interesting experiment to see if cooling would have a benefit in people just with big MIs. So I think the question's still out there, apparently, that this doesn't settle it.
And it won't settle it either, because interestingly enough, in a very small subgroup of patients who died, the cooling actually seemed to produce a mortality benefit.
Sure, so there was a reduction in heart failure with the hypothermia. Now the number of events is low, so the composite of death or heart failure was 2 events versus 8 events. So statistically speaking, it's not a robust finding, but the p-value was less than 0.05 for that, so I think it does generate some excitement. I mean, this was really a small pilot study, but I think it leaves open the door for a larger clinical outcome trial to see if hypothermia really reduces important clinical events.
When you say it's hard to do, yeah, it'd be hard to do, but of course if you did generate heart data that said you were really benefiting people, I think we could find technologies that would get it done.
I'm sure we could, and for me, simplistically, if I see heart events are 4 times more frequent in the patients in the control group than the treated group, I say, gosh, that might be worth pursuing.
Yes.
Because infarct size, of course, as we all know, is something, it lacks some precision.
Right, but the heart failure finding, I agree, it's very intriguing.
Yeah. Well, another very interesting study was additional data on this heart flow methodology for measuring FFR by CT angio. That the initial study was positive, but leaving a certain amount of inaccuracy that raised questions. So they've enhanced the algorithm, and they've been much more specific about the technique of obtaining CT angios. And so with this new methodology, they went ahead and saw how well the CT FFR correlated. What did you think of that study, Deepak?
I think the data for that whole imaging modality looks terrific. I mean, it seems like it's very promising. Invasive FFR, of course, has taken off and has been shown to be really valuable in determining which lesions should be treated versus which shouldn't. And I think the idea of being able to do things non-invasively really takes it to a whole new level. So I'm really excited about that.
And of course, the bane of CT angio has been the calcified lesion, And the overestimation, actually, typically of the severity of lesions or just the inability to even make a quantitative assessment of many lesions by CT. And so the question they asked was, between the visual assessment and this non-invasive FFR, could they more accurately predict what the classic FFR invasively obtained would be? And they got a benefit. I guess that would be of value in determining which patients to move on toward cath and intervention.
Yeah, you know, anything that improves the precision of understanding the severity of lesions, whether the lesion is important, and whether, more importantly, whether fixing the lesion or opening it or stenting it or bypassing it is really going to produce a result. This is all progress, but I think it's still a work in progress, because we know that invasive measured FFR has been shown to improve our overall outcomes if we act on that evidence. The golden chalice would be to somehow have a non-invasive box you get into. It tells you anatomy, it tells you your physiology, it tells you the result you'll have once you're fixed. And so this would be a great dream, but it's exciting, and we should be following this very closely.
Yeah, and our screening techniques clearly have been imperfect. Lots and lots of patients going to cath who don't have obstructive disease that warrants revascularization. But in terms of FFR, there sure are a lot of patients right around 0.8 that give you gray hairs when you're trying to decide what to do.
Yeah, I think the important thing is that we understand that it's a guide. It's part of the evidence. It's not, and so if people get confused, if they think 0.81 you do one thing, 0.79 you do, forget it. I mean, because you measure it again, it's going to go the other way. So it helps you, but it's not a dichotomous decision maker for you. You still have to think.
Yeah, no, I agree with that, and I'm glad I'm not the only one that always seems to get an FFR of 0.82 and somebody is kind of squirrely chest pain, and then you're just as stuck now as you were before. But I think improvements in the technology like this, coupled with future outcome studies to show that this data is actionable in some way, that's how the field's moving.
Yeah, I ascribe to the king approach. If I have a patient that I don't think needs something and they call me up with an FFR of 0.78, I tell them to measure it again a couple times.
Keep measuring until you get the answer you want.
Keep getting something that goes along with the patient I'm seeing in front of me. I guess a word about advice too is in order, and that's the instantaneous FFR, the approach where adenosine is not needed, in the hopes of making it an easier procedure that people would do more frequently.
Yeah, I think the idea of simplifying FFR is good, though in all honesty, I don't think FFR as it is right now is that complex. I mean, just an adenosine infusion is not such a big deal. But if we could, in a percentage of patients, not have to go ahead and give adenosine, yeah, that would make things simpler. I think the field remains pretty controversial, though, in terms of how much this technique really adds. That is it good enough for prime time?
Yeah. Spencer, what's your feeling about the instantaneous FFR?
I don't know. I mean, I think it's interesting. I think it comes close to the same thing you get, but contentious is a good word. To me, one of the main side effects is we've got real discussions at the meetings now that we used to have years ago, where people get right serious about confrontation. But aside from that, I think it's, I need to know more about it. I clearly understand the adenosine FFR. It's like measuring the gradient across an aortic valve, increasing the output. That's very clear. Gradients of that sort are very clear to me. The instantaneous FFR is a little more esoteric to understand, but the evidence is that you get pretty darn close to the similar findings.
Yeah, and we published a lot on IFFR, and just recently accepted a manuscript where a number of investigators pooled their data together, and the answer was, just as you say, it comes close. But the real issue, is it close enough? Is it good enough that you can really act on it? And At least my read on it at the moment is that the answer is not yet.
Yeah, I agree clinically, though I think from a research perspective, it's terrific that so many investigators are thinking about physiology again, you know, not just focusing on the anatomy.
Yeah. So, positive news about CT FFR, some additional information about instantaneous FFR, and negative information, I guess, about cooling in the setting of acute MI, at least with regard to overall infarct size. Many more very interesting late-breaking clinical trials soon to come. Stay with us.